Hello, welcome everybody. Thank you so much for joining us. I'm honored to be joined today by our partners at Caring Across Generations, my colleagues here at Families USA, and later by a Medicaid enrollee, Irene Osorio, who lives in Pennsylvania and who will share her story and fears as critical changes lie ahead for the Medicaid program. Let's get started. This week, the Trump administration is scheduled to release new regulations to institute new work and community engagement reporting requirements for millions of Americans who depend on Medicaid for coverage and care. We are holding this briefing today because this won't be just another administrative action. This new regulation represents one of the biggest of the many cuts to Medicaid coverage in the big budget bill rammed through Congress and signed by President Trump last year. This new regulation will mean new significant bureaucratic burdens on millions of Americans in order to keep their coverage. And while we oppose the big budget bill's massive Medicaid cuts and this specific policy on principle, we also want to shine a spotlight on the timing and the substance of this rule coming out, since the definitions and decisions made will determine how many millions will be forced to fall off of health coverage. This rule really is a critical inflection point for Medicaid, a program that provides health coverage to nearly 75 million Americans, including children, seniors, and people with disabilities, and yes, working families and adults who overwhelmingly work just at lower paying jobs without health benefits. So let me be clear about our opposition, not to encouraging work, but to counterproductive reporting requirements in this bill and in this regulation. While the vast majority of those working age adults with Medicaid work, Medicaid also should be a safety net for those who are between jobs and others who often need health coverage in order to get back into the workforce. When tried, reporting requirements have never proven to increase employment, but they have imposed bureaucratic barriers, which have caused working families to fall off coverage. At a time when Americans are angry about a health system that is too costly, complex, and confusing, the current Congress and this president have doubled down on red tape requirements to make it harder to get on and stay on coverage in both public and private coverage, Medicaid, and the marketplaces. With the budget bill last year and this new regulation, President Trump and his congressional allies are making Medicaid and our health system more costly and complicated. That's not what folks voted for. This administration and the Republicans in Congress argued that they would craft these new reporting requirements to, one, protect the vulnerable, two, be easy to fulfill with perhaps an app or a click of a button, and three, that states would get the time and good faith consideration to put this in place. All so that ultimately we don't have massive coverage losses for those who are eligible and should be getting coverage. And so we'll see with this rule coming out in the next few days how well the administration adhered to those promises, uh, and whether when we finally get the guidance to determine how states will implement this rule. Getting it right matters enormously for states, for our healthcare system, and most of all, for the people who depend on Medicaid to stay healthy and alive. The Urban Institute recently modeled that these decisions and definitions made at the federal and state level will determine whether plus or minus 5 million Americans keep or lose their healthcare coverage. So again, this is not just another regulation that is around the edges. This is a big deal that will have an impact on whether millions of people get on or lose their coverage. So before I pass this on to my colleagues to go into details, I want to make three main points. One is is that while Congress put in place these new red tape requirements, it's states who are in the difficult position to implement. These reporting requirements have been a disaster in states like Arkansas and Georgia that experimented with enacting them to date, creating huge administrative burdens, draining state resources, and leaving tens of thousands of people without coverage due to paperwork confusion and chaos. But what's worse, states are on an insanely tight schedule to put in place these costly contracts with consultants so they start January 2027. So with this rule coming out on June 1st, this leaves mere months to implement what is maybe the most complex administrative change in Medicaid's history, a timeline that experts across the political spectrum have called unworkable. Building IT systems alone often takes 2 years. It takes time to train staff, to set up systems, much less educate consumers about these consequential changes. States have been working in good faith on these preliminary guidance from CMS just to have a fighting chance of meeting this deadline. But now at the 11th hour, we're hearing reports that the White House is pushing major changes to the rule that would contradict the guidance that CMS has preliminary given states. These last minute changes are deeply troubling on both the substance and on the timing. States may have to throw out months of work and start over. And that means that consumers will pay the price for that chaos, especially if the White House is going in a stricter, more burdensome direction and needs to give the states the good faith waivers that are in the bill to push back that timeline in order to do right by consumers. On the specific proposals, on the substance of the proposals, we're particularly alarmed about and will be watching a few potential policies, like the definition of medical frailty as an exemption from the paperwork requirement. One potential definition would go well beyond what the law actually requires, making it harder for the seriously ill or disabled people to qualify for protections that Congress wrote into statute. Imagine being a cancer patient and having to prove that not just that they have cancer, but their cancer prevents them from working, just to keep the coverage that's paying for their treatment. Another concern is how much states can use electronic verification and self-attestation, tried and true tools, rather than forcing needless paperwork and documentation. These changes, if finalized, will affect the most vulnerable people in our healthcare system. These restrictions would violate the promises we heard in the debate on the bill, impacting those people who should be exempt, as they find it harder to prove their exemptions, making this a more cumbersome and confusing for patients. And finally, whatever the federal government does this week, however restricted this rule is, states have an independent obligation to do everything in their power to protect their residents. Within those federal rules, states must build in robust safeguards, maximize exemptions where the law allows, invest in consumer education, and do everything else in their power to ensure no one loses coverage simply because they couldn't navigate a broken system. We'll be working with health, consumer, and community advocates across the country to get states to both mitigate as well as document the damage of this bill. These additional decisions will determine whether millions keep their coverage, and these decisions deserve public scrutiny and protest. So we'll be watching closely, and we'll be holding everybody accountable, from the Congress members who voted for these rules to the governors who will implement them. I thank you for joining us, and I'm pleased to welcome our senior advisor on Medicaid policy, Mary Beth Mulcarney, to walk through more of the details. Mary Beth?
Thank you so much, Anthony. And thank you to everyone for being here and your interest in following this very significant moment for vulnerable Americans who need access to Medicaid. My name is Mary Beth Mulcarney, and I'm the Senior Advisor on Medicaid Policy for Families USA. So as Anthony described, the clock is really ticking for states to implement new Medicaid work reporting requirement programs. But the administration is actively making things worse with possible last-minute changes that could be the difference between adults with significant healthcare needs gaining or maintaining coverage they need to stay healthy. I want to underscore a couple of Anthony's points. By setting up the framework for work reporting requirements, Congress already put millions of people with serious health conditions or disabilities at risk of losing their Medicaid coverage. Now, the White House is threatening to take this a step further by first putting in place a narrower definition of medical frailty, and second, by limiting what's known as self-attestation. So first on the medical frailty front. So states have been having to implement work reporting requirements since almost a year ago, since last July. And they've been in contact with CMS frequently, sometimes on a weekly or more basis, to understand what requirements there may be for them to start to put up these programs. And CMS has been telling states that they would have the freedom to define medical frailty within the parameters outlined in HR 1. And many states already had medical frailty definitions in place in their states for various different programs. And states have spent since last summer, significant time crafting definitions for medical frailty that would apply to the work requirement in Medicaid. And now there's reports that the White House may require that in addition to proving medical frailty, we have to tie that to an inability to work or an inability to, quote, participate in a substantial gainful activity. So this means that people have to prove their significant health condition, but also that they cannot work because of that condition. And that is just much more difficult and not what is required by the statute. So changing the definition, midstream in this way, would mean that states that have spent months defining medical frailty, developing lists of thousands of diagnostic codes that could indicate frailty, drafting screening questions, application forms, all of that, that the work that states have done, they have to go back to square one to start over. And so this change in the definitions here of medical frailty would not only exclude many, many vulnerable individuals from the exemption, but also set up an enormous administrative process for states to go through to determine eligibility and determine work ability on top of that. And that's just one that states are not prepared for and they haven't been preparing for over the last year. So next on the self-attestation front. So states were told that, at least to begin with, at least through 2027, they could allow people to self-report, self-attest their compliance with work or with an exemption from the work requirement. But now there are reports that the IFR may require that everybody submit some more supporting documentation in most or every case. So meaning that someone without supporting documentation could not self-attest to their own health or life circumstances. So having the ability to self-attest is really paramount for people who would meet the medical frailty exemption, but just don't have the paperwork to document their health status. So thinking about an uninsured person today who has significant healthcare needs, but they don't have the medical records yet because they don't have access to insurance and they don't have access to a provider. So here we're really putting somebody in a catch-22 where to get Medicaid and the care they need, they have to have medical documentation. But to get medical documentation, they have to, get on Medicaid, and they can't get through the door without that medical documentation already existing. So this was the reason that states really were hoping and why CMS was giving them the guidance that they would be able to use self-attestation, at least initially, for people like this who won't have paperwork documentation unless they're on Medicaid to help them take care for their health needs. And self-attestation may be very significant for people with certain types of conditions where they don't have frequent connections to the healthcare system. So thinking about someone with substance use disorder treatment, they may not have, a supporting medical claim through their, managed care provider or health plan, right? They may be seeking that type of treatment outside of the healthcare system, and there may not be paperwork to document those types of conditions. So changing course now on self-attestation may make the work requirement process completely unworkable for many vulnerable populations. And I know we'll hear next from Nicole Jorwick at Caring Cross Generations, who'll speak more about how all of this impacts people with disabilities and family caregivers and others. But before we hear from Nicole, I just wanted to highlight that beyond medical frailty and self-attestation, there are dozens and dozens of aspects of work reporting requirements that states still do not have answers to and that they need clarification from CMS on. So just to highlight a few that we are really going to be watching to see if the IFR defines other important terms outside of medical frailty. For example, what counts as community service under the law, or what does it mean to be kind of, quote, part-time in an education program? Thinking about something like a short-term hardship exemption. Well, what does it mean that you're traveling, quote, outside of your community for, quote, an extended period of time for care? The law sets up these exemptions for people that might be in really difficult circumstances, but we don't know what CMS will require of people to meet these exemptions. So these definitions, like these and many others, will dictate how vulnerable populations will gain access to or be kept from Medicaid coverage. Second, we also expect the IFR to define state obligations to data match. So Congress set up a work requirement program that sets out, general expectations that states will automatically verify people wherever they can match people with data sources that may already exist. But how many times are states required to try to data match before they ask people to submit paperwork? In other words, how good of a job does a state have to do before it puts the onus on consumers to submit paperwork and prove their work or exemption? Those will be important things to watch out for in the IFR. And finally, the last one I'll highlight here is, whether CMS in the IFR will allow states to have longer term exemptions. There are many people whose circumstances are unlikely to change. Do we have to really have them prove their exceptions to the work requirement over and over again? Think of somebody with an intellectual or developmental disability, exemptions for former foster youth or incarcerated, formerly incarcerated populations, like different populations who shouldn't have to prove their exception over and over again under the law. So, what flexibility do states have to have a longer term exemption for different folks? So there are countless questions about who will be protected and how they will remain. These are remaining unanswered today, and until they're answered by CMS, enrollees will have no certainty about their coverage. And how the administration answers all of these questions and many others will be the difference between whether states can be ready for a January 2027 launch or whether administrative hurdles put in place are just so high that the program is completely unworkable for states and the people who need access to Medicaid to stay healthy. One last, thing I wanted to highlight that while we await the IFR, we note that CMS just released a proposed rule last week on state-directed payments. So this is an important payment mechanism used by states to increase reimbursement for Medicaid providers and ensure access and quality in the Medicaid program. HR1 already significantly limited payments under this option for hospitals and nursing facilities, and CMS is proposing, as of last week, to go significantly further than HR1 to limit Medicaid provider pay across every provider, including primary care and behavioral health. So I can speak more to the issue of state-directed payments later on, but wanted to highlight this rule coming out just is showing the depth that CMS is willing to go to gut Medicaid beyond the bounds of HR1's historic cuts. If CMS's rule on these payments goes through, that'll cut at least $780 billion over 10 years and reduce provider payment. And we anticipate that the IFR coming out will be no less damaging and that CMS will take HR1's bad policies and give states an implementation framework that will, by design, cause states to cut millions of additional Americans for Medicaid coverage. So we're anxiously awaiting the IFR, and I'm so glad all of you on the call are anxiously awaiting it as well. I wanted to stop there and turn it over to Nicole Jorwick, Chief Program Officer for Caring Across Generations. Take it away.
Thanks so much. Thanks, Mary Beth, and thanks, Anthony. Glad to be here with everyone today. As has been already stated, the administration has already enacted massive cuts to Medicaid through HR1. These were historic cuts to a program that allows people with disabilities to live independently in their homes and communities. Medicaid is so much more than a healthcare program for people with disabilities. It also does provide those services, home and community-based services that keep them happy and safe at home. Work requirement provisions alone are projected to reduce federal Medicaid spending between $300 and $400 billion, leading to millions becoming uninsured, which we've already discussed. But now the mechanism of those cuts, work requirements, puts that independence for disabled people and the hard-won right of people with disabilities to work even further at risk. This is because of even stricter definitions of medical frailty that we're currently hearing rumors of would be incredibly harmful to the ability to work for people with disability. The bill, HR1, defines medical frailty as someone who is blind or disabled with a substance use disorder, with a disabling mental disorder, with a physical, intellectual, or developmental disability that significantly impairs their ability to perform one or more activities of daily living, or with a serious or complex medical condition. That's a pretty broad definition, and that was by design. Critically, nothing in the statute requires a person to show an inability to work in order to qualify for the medical frailty exemption. The law protects people because of their condition, not because they cannot hold a job. But CMS we're hearing, under direct pressure from the White House, is rumored to be considering tying that medical frailty definition to an inability to work. That would be a fundamental rewrite of congressional intent done through regulatory guidance, not through the legislation itself. A massive overreach that creates a catch-22 for disabled people. Either work to make ends meet and lose your Medicaid, or stop working to prove you qualify for the exemption and lose your income. For decades, disability advocates, states, employers have worked to expand access to community-based employment, competitive, integrated employment for people with disabilities. That movement is now at serious risk. Health policy analysts and scholars predict that work requirements, as Anthony stated, will cause insurance coverage losses for more than 5 million people. And it's not going to increase employment appreciably. No data shows that these work requirements are actually going to improve access to employment, and this particular overreach would greatly harm disability employment. If working means you risk losing your exemption and losing your Medicaid, people with disabilities will face an impossible choice. The chilling effect that this will have on employment for people with disabilities will unequivocally undo decades of progress. The disability community has spent a generation proving that independence and employment go together, and we cannot allow a guidance document to make that a reason for people to lose access to health care and other life-giving services that are home and community-based services. Historically, CMS, or the Center for Medicare and Medicaid Services, has deferred to states to define the specifics of legislative definitions, including medical frailty, on their own. States have already begun the hard work of building their own medical frailty definitions and systems, including states that have already implemented and started work requirements early. A last-minute federal mandate tying medical frailty to inability to work would override state-level work that is already underway. Take away the flexibility of the law, which it was designed to preserve, and cause chaos and confusion for people with disabilities and chronic conditions in states that have already begun implementation or states that are just starting to figure it out. This chaos and confusion is something that I know personally. As a sister to my brother Chris, who has autism and lives in a Medicaid expansion state, he has long had goals for community-based employment. And while he may never be able to work the 80 hours required by Republicans in Congress, that should not mean he has to forego the opportunity to work, just so that he can maintain the home and community-based services that keep him safe, happy, and independent at home. Again, this is something I know personally, and this is something, the fear that I hear from people all across the country, from people with disabilities, as well as family caregivers. I can't overstate it enough. We are hearing that things are going to get even more complicated, as Mary Beth laid out, around the idea of self-attestation. If self-attestation is eliminated before systems exist, people will have no way to demonstrate the fact that they qualify for this exemption. This isn't a technicality. It means people, including disabled people and family caregivers, will lose coverage not because they don't qualify, but because the system won't let them prove it. For family caregivers, there's over, depending on what numbers you look at, 63 million family caregivers, up to 130 million if you're including parents and a wider swath of the population. For those family caregivers and disabled people, self-attestation is incredibly important. To Mary Beth's point, for most of those folks, their situation isn't changing. And we have to make sure that for family caregivers who themselves can't work because of their caregiving responsibilities, they also need to maintain their coverage. The law has problems, but the guidance is threatening to make it worse. By narrowing exemptions that Congress didn't narrow, stripping state flexibility that Congress preserved, and creating bureaucratic barriers that will fall hardest on people that the program Medicaid was designed to protect, including people with disabilities. We have a lot of concerns, and we really hope that the overreach that is being rumored doesn't come to fruition because of the massive negative impact it will have on people with disabilities when they're already reeling from a $930 billion cut that passed last year. I'll pass it back to Anthony.
Thank you so much, Nicole, both for your professional advocacy, but also for sharing your personal story. To add to that, I want to introduce Irene Osorio, who is a Pennsylvanian, a parent, who has her own story about depending on Medicaid coverage for her and her family. Irene, thank you so much for joining us.
Thank you for having me. My name is Irene Osorio, and I live in Philadelphia, and I'm here today to talk about why Medicaid matters to me. Professionally, I wear many hats. I'm a seamstress, and I'm a language justice worker. I do interpretation and translation, helping people who speak different languages to be able to participate in their communities. Most recently, I started a worker cooperative with 3 other interpreters. Medicaid gives me stability while I build my business and continue serving my community. That is why proposals around work reporting requirements worry me. Like many people building small businesses, my work does not always fit into a simple schedule. Some weeks are very busy, some weeks are slower. Hours and income can change. Right now, we don't know what reporting requirements or documentation will look like. But we do know that people who are working hard could still fall through the cracks because of paperwork or administrative errors. My life is bigger than paperwork. I'm a co-parent of a beautiful 10-year-old who's the center of my life. I volunteer in my community because it's very important to be of something bigger than just myself. And I'm a small business person. Medicaid gives me the stability to take care of my son, to grow my business, and keep moving forward without worrying that red tape could undo everything I'm working to build. Thank you for having me here.
Thank you so much. Again, just we want to make sure that uh, you, your child, and so many other Pennsylvanians and Americans get the coverage that they need, and so that's why we're holding this press briefing today. With that, I would love to open it up to questions. We have a number of reporters on, so if you have a question, please raise your hand, come off mute, put your question in the chat. Um, well, I'll wait a second. While we're waiting, I'll ask my fellow panelists here. Just we are hearing that again that the White House is potentially going to make this of this guidance, this interim final rule, the IFR, even more restrictive than what was originally contemplated. How would that work with regard to the states that are already going forward? Nebraska famously went at rushed ahead implementation earlier with some of that preliminary guidance from CMS. Um, what's potentially happening, and what chaos and confusion may come from that?
Oh, go ahead, Nicole, if you want to answer, I'm happy to.
I was just going to jump in and say that, I mean, the chaos and confusion has already started in places like Nebraska because they jumped the gun. But the reality is that if what we're hearing is true, and I have no reason to believe that it isn't, and they go further than the statute requires, it's going to require states like Nebraska and others who are already getting ahead to go back to the drawing board, making chaos and confusion for the people who are receiving care even worse. We know that there's so much between eligibility redetermination and work reporting requirements. So many people, I mentioned the fear, but there's also just a lot of misunderstanding about how they're going to get contacted, what they need to do. And so stripping that flexibility from states will add another layer onto an already chaotic situation. But I'll pass it back to you, Mary Beth.
Yeah, well said. I would just add that I worry that, there is at least one person and maybe many people who have received notification that their exemption from medical frailty has been accepted by the state of Nebraska and that they're able to obtain Medicaid coverage or retain their coverage. I worry that, with a shifting sands here and a change in CMS's definition of medical frailty, that folks in Nebraska will have to be redetermined. Somebody that already just got on Medicaid um, may have to go back to square one and back through the process again, which is such an administrative waste, I think, for states to have to do that again, and also for the individuals themselves that just went through this whole process to be asked to do that again. And so I don't know, if states will or CMS will give states some flexibility to rectify that situation so that people that are caught in that circumstance who've already been granted Medicaid coverage, that they can at least remain on coverage in the short term, that they won't be impacted immediately. But that all remains to be seen. But I think there's a lot of work that Montana. Um, Arkansas, other states that are trying to begin the process by July 1, just about a month from now, they're already really far down the process. I wonder if this will push back their timelines for being able to implement. And these are the states that really want to implement soon and want to try to put these programs in place, and they may be stopped in their tracks. But every state has been working on this for months and months. And so all of these changes will impact, I think, every state going forward, and whether or not they're even ready to commence their programs by January.
Thank you both. Are any question from our friends in the media? We have we expect that this is slated to come out at least in the timetable of the law on June 1. And so we wanted to provide this briefing uh, to both highlight the importance of this law. Again, we know that millions of people will lose coverage, but how this rule is put in place is would mean is it 5 million more people or 5 million less people, depending on what the federal government does in this rule and what states do in the implementation. So again, we think this is a there's not a lot of things that happen over the course of the last several decades that have an impact on whether millions of people keep or lose coverage, and so this deserves that kind of focus, and that's why we wanted to be resources both as folks are prepping the stories, as folks are seeing. As the White House is making some of these decisions about what is the interim final rule that they put out, but then also once it comes out, I think our organizations and others will be resources for the work ahead, whether it's litigation, whether it's the state implementation, or otherwise. Any final, go ahead, Dorothy.
Yes, hi. Thank you for holding this call. You mentioned Nebraska. We're now what, 25, 26 days into Nebraska's implementation. And this is the first chance that we've been able to see OB3 being implemented in terms of the work requirements. How has that process been going overall?
Hi, Dorothy. It's a little hard to tell. People that were already on Medicaid in Nebraska haven't yet uh, had to prove, to redetermine their Medicaid status. So at the moment, for folks in Nebraska, it was really the people newly applying. Um, and so it's hard to know, who applied and was turned away, right? Where's that documented? And um, I think it's going to take a while for all of this information to come to light. But, I think part of the story here is how good of a job did Nebraska do in informing people of the law? How many people never even knew about it, didn't even know what the requirements were, applied to Medicaid because they thought they were eligible based on, other factors, based on income or other factors, and were turned away and never knew why. That, they might not have been given an explanation that they were turned away because of they didn't fulfill their paperwork to prove a medical frailty, for example. So I think it'll take time for some of these stories to come out. Nicole, you may have other thoughts, though. Look like you want to come on.
Yeah, so we convene a couple times a month a group of state level advocates and have been really lucky to hear a lot from folks in Nebraska working on it. I would say I would agree with Mary Beth that some of it we're not going to see until some additional time passes. But as a, I think, important data point, their medical frailty exemption was hundreds of pages long. So for any lay individual, disabled person or family caregiver or care worker who's helping somebody navigate this process, it is going to be onerous. This isn't burying someone in red tape, it's beyond that. And so I think it's going to take some time to play out, but and again, they might have to go back to the drawing board depending on what comes out from CMS. And so I just think Nebraska is chilling in the complexity that they're going with, and we know that complexity is going to cost people coverage, and unfortunately, in some cases, cost people, life-saving care.
Yeah. I think in terms of a timetable, we do expect that we'll start to get anecdotal stories of people who may have been dropped from coverage or otherwise by August, just going into the cycle of things being implemented in June, July, and then starting to see the anecdotal evidence. And we'll start to see the data of people falling off coverage in around like October, November of this year. But again, I think we'll have anecdotal stories earlier as those impacts hit later in the summer. I would say that we are already getting from our partners, and we're happy to connect you with our partners in Nebraska, Appleseed, and other places, of just the confusion of folks who are going through the hundreds of pages of aid codes of who's potentially Medicaid exempt, and people trying to figure out, do I qualify if a related condition is listed but not the one that I'm specifically have, or some of the issues with regard to um, uh, again what documentations they have to put forward in order to uh, get processed and to prove their exemption. I will say that as much as Nebraska was gung ho and rushed to implement these requirements, if the current expected guidance is comes out, that would actually undo a lot of what Nebraska is, because the federal guidance is significantly more restrictive than even um, a state like Nebraska that was gung ho about doing this. So I just wanted to uh, highlight that as well. But I do think that it's going to be really important to hear from the storytellers, the people who are having the impact, folks, whether it's like Nicole's brother, like Irene Osorio and others here on this call. Other questions? Going once, going twice. If not, if folks want to raise their hand, otherwise, I would just say I want to just highlight that, again, even though we are opposed to the principle of this new regulation, Medicaid should be a safety net for people between jobs, people who n need health care coverage that can rejoin the workforce. We the the details do matter, and I think there's that what comes out by June 1st, I think will have really big implications on the timing of this and on the substance of how many people fall off of coverage, and even the timing of whether this is workable or not. Again, the issue of how do you uh, if you were a cancer patient who may be in remission, if you were a cancer patient and cancer patients are exempt, you could actually find that out from claims data, and you can do that electronically. If you now have to get uh, a clinical diagnosis that your cancer does not allow you to work or not, that is a far more cumbersome and maybe even unworkable process. And there are literally dozens of decision points like that that need to be made. So states need time, and states need more thoughtfulness about how impl these uh, rule these rules come into place. We hope that that provides a little bit of context for when the rule does come out in the next week, and we hope this has been helpful. Aaron, did you have any last logistical issues?
Yeah, thanks again, everyone, for joining us. I just wanted to repeat for anyone who joined us late that we have recorded this session and we will share it out with everyone who RSVP'd afterward so that you have that. In addition, as Anthony mentioned, once the actual interim final rule comes out, we will share a rapid response statement as immediately afterward as we can, as well as a longer policy analysis coming shortly after that. And of course, are available for one-on-one interviews. So just don't hesitate to reach out. Thank you.
And with that, thanks everybody.